Good afternoon, everyone, and welcome again to the Community Research Academy. This is part of our Spring 2021 virtual lecture series. I'm so delighted that all of you are here today. We have two great speakers. Today we have Natasha Ashley. She is a health nutritionist. She has a Master's of Science. She's a registered dietitian. She's a certified dietary nutritionist. She has experience in nutrition stemming from being a public health nutritionist supervisor, director of dietary, registered dietitian in Florida, then continuing in New York, where she has followed to be a clinical dietitian at St. Barnabas Hospital, and now she's the Regional Nutritional Coordinator at Cornell University Cooperative Extension. She is highly skilled and effective registered dietitian and nutritionist with extensive experience in clinical and community health. She is skilled in evaluating the nutritional health and wellness of clients from diverse backgrounds. Developing and achieving achievable dietary plans and implementing plan compliance. Ms. Ashley has built a dynamic rapport with her clients, driving personalized health initiatives that will improve their quality of life. Today, Ms. Natasha Ashley is going to talk to us about nutritional app development in preparation for clinical trials. And the next voice that you will hear will be Miss Natasha Ashley. Miss Natasha Ashley, welcome to the Community Research Academy. Thank you.
That was such a wonderful introduction. Thank you so much. Hello, everyone. Hello. Thank you so much for having me. I am excited to be here and tell you a little bit more about nutrition and health research. And at the end, I will discuss my app that we are developing with the CTSC. So I will get started by sharing my PowerPoint presentation. I have done, I don't know if you know, but Zoom has a new feature on it. So I'm gonna try it out. Well, I've tried it already and see if it works here. It's pretty cool since we are a part of the CRA. Let's see if I can find it. All right. All right, can everybody see?
Yes.
Perfect. That's so cool. I didn't see that before. What?
It's so cool.
Wow.
I love it so much. If it gets distracting, just let me know and I'll move my head to the side or I will take my head off.
No, I think it's great. Keep it going.
It's so great. Yeah. I love it so much. Okay. I just want to let you all know that this is something that's in beta phase now in Zoom. So once you go to share your screen and you go to advanced, right in the left-hand corner, it says beta. And I think it's like share screen presentation, something of that nature. But I've been telling my staff about this and it's really great. You get to see yourself, yes, of course, but you get to also see the participants and you can split your screen. So if you have any notes, you don't have to necessarily have them on your PowerPoint presentation. And this is just a side note, just because I'm excited about it. You can split your screen and see your notes on the side without having the PowerPoint presentation covering the whole thing. So please try it out, okay? So I guess we can get into the presentation now that I've introduced you to something new, hopefully. So anyway, thank you again, Lula May, for your introduction. Again, my name is Natasha Ashley. This is one thing, you got to scoot over sometimes for your slides. I am a registered dietitian and I work for Cornell University Cooperative Extension as a nutrition and health program coordinator for the Brooklyn and Queens region. Okay, so again, I work for Cornell University through the College of Human Ecology. And so through Cornell University Cooperative Extension in New York City, there are many programs. And so some of the programs that we have are the hydroponics aquaponics program, 4-H youth development, family and youth development, and nutrition and health program, which I am a part of. And then we have the expanded food and nutrition education program. Lots of acronyms here. You will see EFNEP over and over again. You will see ESBA, which is Eating Smart, Being Active. Choose Health, Food, Fitness, and Fun, which we call CHIF. And also Healthy Children, Healthy Families, which is what I will touch upon a little bit more, okay? So what is EFNEP? I know this is a lot, but I want to make sure that you understand what this is. And so EFNEP represents a federal and state land grant. So the land grant is through a university in the United States. So through Cornell University in New York, for example, in Florida is through the University of Florida, and creates partnerships with supporting nutrition security of low-income families. So we have peer educators that develop group and individual nutrition, deliver group and individual nutrition education that's tailored to the needs and the families in their communities. So that is what is a part of our program. We like to take people or educators from the community. They know the community, and many of the participants are a part of the workshop. They graduated from the workshops, and then if we have positions open, then they are our nutrition educators, and that's even better because they know exactly who their audience is because they were a part of that audience. We also have very interactive sessions that support improved behaviors like food safety, food prep, food resource management, and different nutrition topics like that, and it leads to our program success. And some studies have shown that these new behaviors are not only maintained, but they last a lifetime and they last across generations. We have lots of grandparents who've had kids who are now part of EFNEP and who had kids who are now part of the youth programs that we teach as well. So it's generation after generation after generation. And it results in lasting change. So the annual data confirms that graduates improve their diets, their nutrition practices, they stretch their food dollars, and they handle foods more safely, and also increase their physical activity levels. And so this is some data that we have from 1999 to 2018. So this is from New York City. We reached a total number of about 60,000 participants, and this is from these specific years. Total family members, almost 250,000. Program graduates was at 82%, about 50,000. Youth participants, 57,000, almost 58. And total youth groups, 3,400. And for 2017-2018 year, we had 5,000, just about 5,000 in just 1 year, the amount of adult participants that we educated. Family members, 2,100, program graduates, about 4,000, and youth, you see here for 5,000, and groups, 267. And the racial background is majority Hispanic, Latino at 63%, 18% Black or African American, 15% Asian, 4% white, and 1% Indian or Native, Alaskan Native, my apologies. And this is an example of a behavior questionnaire. This is how we take these measures and see if there have been any behavior changes. So if you squint a little bit, no worries, we're not gonna go through this too much. We have some questions on here, like how many times a day do you eat fruit? How many times a day do you eat vegetables? Over the last week, how many days did you eat a dark green vegetable? So we give these questionnaires to our participants at the beginning of the workshop, and then we measure it again at the end of the workshop so we can see how their behaviors have changed. Of course, we're working now remotely, 100%. So we've found a way to deliver these workshops via Qualtrics, a Qualtrics survey. So it is digital now. And some of the adult behavior changes that have happened, 76% showed improvements in one or more food resource management practices, 78% improvements in one or more food safety practices, 79% one or more physical activity behaviors, and a whopping 91% showed improvements in one or more diet quality indicators. And this is just a snapshot of what we, the participants that we've reached in the 5 boroughs here. So we have every dot represents an agency that we are a part of. And of course, this is pre-pandemic, but you can see we are spread far and wide across New York City. And so let's get into the research project that we did about about 4 years ago. Healthy Children, Healthy Families, Parents Making a Difference. And this is one of the curriculum that we have. So it integrates parenting and nutrition education in a dialogue-based, hands-on format. And dialogue-based is very important because we are having those conversations with our participants. It's not as straight on as the ESBO, which is Eating Smart, Being Active. There's lots of conversations going on because when you are parents, there's dialogue. There's talking amongst parent to parent and also between that educator as well. They're innovative interventions, feasible, and they're engaging, definitely, and acceptable for parents and extension staff. So this study aims to provide research-tested evidence for Healthy Children, Healthy Families curriculums to show its effectiveness, to see how it can be used and if it can be used in the EFNEP programs across the US. And don't worry, you do not have to squint your eyes. I have made this a bit bigger on the other slides, but this is the poster that we use when we're going to different states to show what we've done. And so I'm going to break it down just a bit for you. So for the Healthy Children, Healthy Family curriculum, there are definitely key modifiable behaviors that influence your children's weight. So this is one of the goals, is to make sure that there is some form of influencing your child's weight, because we know obesity is such an epidemic here, not only for adults, but also for children. It focuses on parental influences in preschool years. So that's what this study was specifically for, parents with preschool age children. The interventions include knowledge and skills, attitudes that parents need to influence their child's behavior. And also it was developed and tested in collaboration with other extension programs in New York. And at the bottom, you can see, so it's small, I can read it out, different curriculum components within Healthy Children, Healthy Families. So we have an intro here, think your drink, eating more fruits and vegetables, physical activity, making healthy choices easier, sitting less, reducing screen time, very important, having sensible servings and family meals. And of course, we have to have a celebration at the end, which everyone enjoys. I like going to see those celebrations and being a part of them as well. So different objectives that we have here. So objective 1 was just to determine how the impacts of the curriculum were on low-income families and the EFNEP program, and how these parenting practices influence their children, their eating habits, their active playing, compared to those that had delayed intervention group in the control group. And the second objective was to investigate parents' retention to these changes. And I think we'll go over it in the next slide about the delayed intervention group, and it just shows it down here at the bottom. Let's go to the next slide and see. Yep. So there were about 400 parents and caregivers that were recruited from different Head Start programs in New York City. And again, there was an intermediate education and a delayed education. So at the bottom in this box here, I hope you can see my cursor. There was like a baseline group here where some of them had the education immediately from the beginning, and some of them had a delayed education. Then they received the education here, and then there's a follow-up. So there we had to have 2 different groups. Of course, they were in English and Spanish, just to make sure that everyone was getting the education that they needed. And then there were a randomized controlled trial. Okay, so parenting practice, some outcome measures were self-efficacy, different parenting practices, diet quality, physical activity, retention of behavior changes longitudinally over with our follow-ups as well. We also measured using validated Healthy Children, Healthy Family behavior checklist, similar to the one I showed you earlier that we use in our ESBA guidelines. And with that information, we input it into Webners, which is our data collection system that we use in the state of New York. So data were collected 4 times by data collection staff using validated measures. It provided information for behavior changes. Okay, so some of the outcomes for adults were improved diet quality, increased consumption of fruit and vegetables. For children, just about the same, low levels of regular soda consumption, which is awesome, high levels of physical activity. And for parenting, increased frequency of adults letting their kids decide how much food to eat. Okay. So in conclusion, well, some of the conclusions and implications are that the graduates showed significant improvements in their diet quality for themselves and also for their kids, and that information was retained over time. So that means that Healthy Children, Healthy Family curriculum is an effective intervention for both English and Spanish speaking participants, and that it can be used in the United States and not only just here in New York City or in New York State. So we got a thumbs up for that. So let's go on to the nutrition app that I was telling you all about. So the background on this is that I am also a part of the CTSC committee that we have. And so they reached out and just asked if there were any people in the community that had ideas for apps. And I had an idea for a nutrition app. I previously worked in clinical nutrition in a dialysis center. And I had a lot of patients who were very frustrated with what to eat and what not to eat, since the diet for those that are on dialysis is very restrictive, super restrictive. And so they would say, well, what am I supposed to eat? What can I eat then? I just need for it to be simple as possible so I know yes or no. So from that, I was like, okay, we can come up with the app for that. And so I had an idea, and it's been an 18+ month long journey. It's been great though, so I'm going to show you a few things. So again, it's a simple two-step process, and that's what differentiates it from other nutrition apps. There was MyPal, there's so many other ones, but I wanted it to be very, very simple for people who have medical conditions or don't have medical conditions and just don't have the time to feed through or sift through all of these different foods. So once you start the app, you're adding your height, your weight, your gender, also if you're diabetic or not diabetic. And the plan is to increase the amount of medical conditions on there. So heart health as well, for anybody who may have kidney disease. Those are all different medical conditions that have nutrition ranges depending on what a nutrient, vitamin, or mineral it is. The equation is suggested for the macro and the micronutrients for the day, as I was saying. So you essentially scan foods, and then there's an easy answer. Let me scoot over. Oh, that's it. There's a stoplight. So it should be red, yellow, and green. And that's how you know green, yes, go. Yellow, slow down. And red, maybe not, okay? So we have a demonstration. My computer was not acting nice today. So I recorded the demonstration, and so you all be able to see it now, and I'll talk you through it. So where will it let me play? And it may not. And this may be the downside of this feature. I apologize, everyone. What I'm going to do right now is stop sharing, and I want to just give you the regular one. I apologize. No beta for this, just the regular old presentation. Again, my apologies.
While you're doing that, I saw comments in the chat. Somebody asked if they're able to receive the slides.
Sure, absolutely.
Okay.
All right, back to the regular old way. Here we go. No worries. All right, so for our demonstration here we go. All right, so this is me now scanning a food here. So we have chia seeds here. So I scan the food, and then what comes up on the nutrition app. We have organic whole chia seeds. You see the serving sizes, number of servings, and you see that increase in your calories, your fat, saturated fat, carbs, protein. When you move on, you can see the exact name of the food that you have here, and it just goes a little bit more in depth with what these foods are. How many calories it has in here, saturated fat, protein, and also the ingredients down here at the bottom. Just chia seeds, that's about it. And so we can go into the log now, and in the log, you can see more specific details, 127 calories, and then you can add this to your logged food so that you can keep it for a little bit later on. So we're gonna scan something a little bit different now. And so we got some Tostitos tortilla chips, and you can see that the calories has added on a bit now. I am going to increase the amount of servings that I'm having, and you can see the calories, the sodium increase as I am going along. It will also decrease as well. So I'm increasing it just a little bit more, and you can see that the amount of calories that we suggest that you have is increasing, and now we're in the yellow, and that's where we had that green, yellow, and the red. I'm going to decrease it just a little bit more to 5 servings here, and then we're going to go into the details. So again, you can see the number of servings and see how those calories, a little bit of the fat increased as well, and that sodium increased too. We have our ingredients in here, not as simple as we had with the chia seeds, it's okay. And then we go into the log here. And for the log, again, we have it's added onto it. So we have the chia seed amount and the tortilla chip amount on here. We're gonna go into the log foods, and you can see that both of them are in it. So we're gonna go back a bit and then add one more thing on there, okay? So what do we have now? We have some Nabisco whole grain crackers, okay? So we have 2 different ones on here. So you can choose which one that you would like. It can be just the regular whole grains, or it can be the wheat thin crackers. So I choose one of them. And again, you can see the addition on to what it was before. I'm going to increase the amount of servings that I'm having. Oh, we get into the yellow here. We have 7 servings, and I'm going to increase it a little bit more. And so now we're in red. So now it's like, wait a minute, just a bit too much now. Are you going to stick with it? I think I stick with it. And we're going to go on to the details. Okay, so see those calories, it's increasing now because now we have added on something else to what we're having. Ingredients increased a little bit more. Of course, that's just how it is with these Nabisco crackers. You can also heart this and favorite at the top. You can see if you want to keep that as something, if that's something that you usually consume. And then we are going to go into the log. Now we're at 2,272 calories for those 3 items. And the 3 items are added here. Okay, I believe that's it, yeah. So, summary, this is the beta phase of this project. So we are going to try and release it sometime this year. We've been working on it for a while now, but we need more users and we need more scans. We need you to scan, scan, scan away. So I am hoping that Lula May and Agnes will be able to include this in your information so that you'll be able to click on it or copy and paste it and be able to use this app as well, so we can gain more information and increase our data. And that is it for me. Thank you so much, everyone. Let me know what questions you have.
Thank you. I don't see any questions in the chat yet, but anybody can speak up if they have any questions about anything.
A quick question.
Yes.
And you'll let me know, please, Miss Ashley, whether or not this is in your wheelhouse. In a nutshell, in the last 100 years or so, Black farmers in particular were removed from the landscape of their farms, particularly in the Deep South. That radically began to change the nature of farming in the United States, which then, of course, impacted migration shifts to the north, as well changed the manner in which food is brought to the table of Americans. Some of this was structural racism. Some of this was the quote unquote law of unintended consequences. But the bottom line is the Black farmer of 100 years ago has now been replaced by the poster child for the biggest farmer in America, Bill Gates. So that's 1 century of change. Now, to what extent do you see on the micro level that macro change impacting how not only we've seen it during the pandemic, the absurdity of an orange having to travel 3,000 to 6,000 miles to get into my tummy? I mean, that's ridiculous. So we all now know the virtue of supporting local farming bringing produce to market locally. Think locally, eat locally, feed locally. How do you and your colleagues, if at all, seek to influence public policy to not so much take the profit and the profit center out of food production, because clearly it is here to stay?
Mhm.
Food is big business, certainly in the United States. How do you work around that? Do you think about that? Do you talk about that? Do you wish to advocate to how to bring the small farmer into the mix of local communities, both to enhance the quality of what we eat, as well as allies of the good work that you and your colleagues are doing, particularly in the education of communities? Thank
Yeah.
you, Ms.
Great question. What I will preface it by saying is that I am not an expert on farming and nutrition. I'm not an expert on food justice and nutrition. Community nutrition and clinical nutrition are my specialties. What I will say is that I completely understand what you are saying. Farming has been greatly impacted, period, and also definitely has increased during the pandemic. So a lot of the
I think she just, oh, the connection got low. Okay. You're muted.
my apologies.
Okay.
So again, technology is not my friend today. But like I was saying, that was a great question. Farming now, again, is a lot different than it used to be. As you said, there are lots of different companies like Monsanto that have kind of taken over what the smaller farmer has, or what they were previously. And that there is a process from the farms to now. There is a process from what foods used to be back then to what they are now, because there are a lot of processed foods, a lot of cutting corners and things of that nature. So are you guys hearing me?
Yes.
Yeah.
Okay, everyone is frozen, but it's okay. What we do is that we in our EFNEP program and community health and nutrition is that we understand that the prices have increased, there have been a price gouge. And so what we do now is we have different topics, especially during the pandemic, that touch upon stretching food dollars. So for example, our nutrition educators give this education to their participants and ask them, what do you have at home? Where are ways that you can try and stretch your food dollars a little bit more? Can you look at unit pricing instead? Can you use coupons? How can we use coupons? How can we use the food that you have at home? How can you make a list so that it's stretching the food dollars? Because in all honesty, there's not much that we can do at this very moment. We have people in policy and politics, somebody like Marion Nessel, who was my professor, who leads the charge with food policy and politics. So that's what we do. We support programs and people like Marion Nessel and programs like the Nutrition Health Education Program of New York City that talk more about this, and have lobbyists and speakers as well who just advocate for what we do. In the Nutrition and Health Program, we just try our best to speak for the participants and what they're doing in the community. We also have a farmers market nutrition program. In this program, we have educators that go out, they give nutrition education, and they have food demonstrations for those farms, from those foods that have been farmed by the farmers. Bring it out, bring different recipes, and show you how you can use these foods in a way where you're not adding any additional salt, it's not processed. So we are, touching upon things in a smaller way, not necessarily in food justice, not necessarily in food politics, but something that participants can use now in their homes to help improve their family and their friends' behavior changes in their education.
Thank you. Thank you, Ms.
Welcome. I'm sorry.
I'm just gonna read what's been said in the chat. Jazzy agreed. She said, great insight from Ms. Scanlon. Amazing. This is so true. I do believe that the way food reaches urban tables and more via structural racism. And Diane asks, please clarify if HCHF is available to families and communities now. If so, how do they access the program? If not, when will it be available and how? And Jennifer Tiffany said that the whole set of issues are at the core of what Cornell Cooperative Extension works on in New York City and statewide. Thanks so much for articulating these issues, Francie. And that Natasha's program works in partnership with programs that focus on local agriculture and also social equity work against structural racism. These include urban agriculture, farmers markets, seed to supper, hydroponics, aquaponics, the small farms program, and the farm workers program, and many more. It's a lot of programs.
Thanks, Jen. and for the person that asked about our Healthy Children, Healthy Families program, we are delivering that program now. So you can email me, or if you have, I'll put my email address in the chat here. So if you have anyone that is interested in this program, then you can definitely be involved. And we give about 8 to 10 workshops, and you get a wonderful certificate at the end with Cornell's information on there. So I will put my information at the bottom at the chat, and please feel free to reach out to me.
Okay, I'll also CC you on the email later that I'll send to the group then. It'll include the slides and the links and any information you would like to share also.
I have a question regarding the app. I want to know if we could scan food or we have to scan labels.
It's both. It's both. Thank you for bringing that up. So you can scan the foods, but for example, an apple doesn't have a scan code on there. So you can just put in an apple and it'll come up. It'll ask you like what size, a medium apple, a small apple, green or red. So it's not only foods that you scan, it's other foods as well.
Okay, thank you.
You're welcome.
Diane followed up and she said, I appreciate this approach because it places critical emphasis on the parental role in nutrition, child weight and health, as opposed to blaming or shaming the child. While it models a collaborative approach, parent and child, to nutrition intake and management, how does the program address special needs or chronic needs, especially with youth?
Well, special needs and chronic needs, our educators are not registered dietitians. I am a registered dietitian. We have 2 other registered dietitians that work for our program. So we are taking people from the community, usually people who are graduates of our program, and we do an extensive training on nutrition and health. Now, some of it may touch upon different medical conditions. For example, when we talk about physical activity, that increases heart health. When we talk about portion sizes, that may include those people who have diabetes. But specific medical conditions should be touched upon by a registered dietitian. And so if there's anyone that are in our educators' classes or workshops that have questions about their specific medical condition, we tell them to consult their practitioner. And if they want they have any questions about directly nutrition and their medical condition, they can speak to a registered dietitian that's in the program.
Thank you.
Wonderful. Thank you. Okay, so I think we're going to move on to our next presenters. Lula?
Yes.
Okay.
Yes.
You're ready?
I'm ready. Thank you so much, Natasha, for a beautiful presentation. It's so informative. And next we have Dr. Alejandra Aguirre. Dr. Aguirre has over 18 years of experience in public health practices and research in community engagement, community-based participatory research, health education, and health literacy. She has collaborated with organizations nationally and in Latin America on capacity building efforts around programs design, implementation, and evaluation. Currently, she is the Assistant Director for Community Engagement at the Irving Institute for Clinical and Translational Research at Columbia University, Irving Medical Center. The mission of the Irving Institute Community Engagement Program is to stimulate academic community research partnerships and enhance the translation of research development in public stakeholders. So I'd like to welcome and thank Dr. Alejandro for being with us this morning. And I thank you so much for all of your work and encouraging community members to get involved in community-based participatory research. Dr. Alejandra will be the next voice that you will hear today.
Thank you, Lula May, and thank you, Agnes. And it's great to be back in this second cycle of the CRA. I do want to introduce my community partner, Ms. Fern Hertzberg, who will be co-presenting with me today. We'll actually be talking about a CBPR project that we are finishing, and also highlighting how it's actually is the foundation for some new initiatives that we hope to take on and build. So I apologize, because after following Natasha and her Zoom expertise, we're going back to just basic Zoom. But I am going to try, let's see what happened here. But I am going to try that tip. That was great. So let's see why this
It's okay. It's the first time I was saying it too, so we're all in this together.
I know. I commented that she was a great ambassador for the Zoom new rollouts, new feature rollouts. All right, let's try this again. And while I do that, let's see. All right, now you should be seeing our slide deck. Okay, I see Agnes, she says yes. Great. Okay. So as Lula mentioned, I'm Alejandra Aguirre. I'm with the Irving Institute for Clinical and Translational Research at Columbia University Irving Medical Center, and I've had the personal and professional pleasure to work with Ms. Fern Hertzberg. Gosh, I want to say that we're probably knocking on 15 years. So it's another reflection of long relationships when doing community engaged work and community-based participatory research. So I do want to introduce Ms. Hertzberg. She's the executive director of ARC 16th Fort Washington. She is a well-known community leader in Washington Heights, Inwood, and Harlem. She actually oversees 3 senior centers, 1 in Washington Heights, 2 in Harlem, and she's also the co-chair of the Washington Heights Inwood Council on Aging, which is a collaboration of over 30 senior service organizations advocating for seniors in Northern Manhattan. And she has many, many other roles that would probably take easily 30 minutes for me to review. But you get the idea of who she is, the role, the leadership role that she has in the community. And she's been working in the community for what, Fern, 40 years now?
Oh, you're on mute, Ms. Hertzberg.
35 plus years, most of it in Washington Heights, Inwood, and Harlem, though I spent 9 years in the South Bronx.
So she's toying with retirement, and I'm trying to convince her not to. So again, it's a pleasure to be here with you, and to also have the opportunity to co-present with Fern on this and on our special project that we also want to share with you, and as an example of community-based participatory research. But before we can get to defining and discussing what is CBPR, we need to start with what is community engagement in research. And so this is the Community Research Academy. And although so we're going to discuss community engagement within the context of research. But it's certainly not limited to research. Anyone can engage in this approach. It is not, limited to research. Certainly, we're here as an example to show you how Fern's organization does community engaged research and how they've undertaken community-based participatory research. So what is it? It is a meaningful involvement of patients, caregivers, your organizational clients, the community that you serve. It could also be clinicians and other stakeholders such as community-based organizations throughout the entire research process. If we're talking about community engagement within the context of research, community engagement is meaningfully involving your stakeholders in the entire research process, from planning the study to actually doing the study and then disseminating the study results. That means informing your stakeholders of the findings, going back to your community and letting them know what you found as a result of doing this study with their engagement. And so what are the benefits of community engaged research? And this is coming from the data. This is coming from the literature. There is data that shows that involving your stakeholders in projects improves the agenda because they're able to prioritize what is important to them. And we'll actually talk to you about how, because we engaged our community of older adults, they actually identified their priority and they set the agenda for the project we're going to share with you. It also makes it likelier that the design and delivery of the project will succeed because there's an input from the target audience. It's also the findings are relevant to the community because they've been informed and been part of structuring that project. And therefore the outcomes or the findings out of those projects are much more relevant to the community. Also, community engagement engenders public support for projects and for health research. So by involving the stakeholder community in the process and valuing the contributions that they have, it leads to greater support for service and research projects. And also the value of community engagement is that the partners gain a better understanding of the issue that we are either trying to better understand through research or that we're trying to address through a service project. And so their community engagement can take many different forms. And this table shows you from the more basic of outreach, which is the least amount of community engagement because it is one directional, meaning we are trying to reach and identify and reach, whether it's clients or participants, and we're providing the community with information. We're not trying to actually involve them in any of the process. We're just letting them know that we exist and what we offer. And as you move from left to right, we can engage in consulting the community, where the communication flows from the community and again back. Usually, we do it by, say, doing a questionnaire. Let us know what you think. But they're not really at the table. They're not engaging with us in substantive discussions and planning the changes for our projects or our studies. That really happens when we get to the far right under collaboration and shared leadership. And that's CVPR, when the community is at the table. When the stakeholders that have a role in addressing the issue at hand are also sharing in the leadership and the responsibility, and we've made the space for everybody to be heard. And so that's when we start to get into CBPR, when it's bi-directional. The engagement is meaningful. We are considering their what they're saying, and it is being reflected in the way the project is being carried out. So this is a graphic of the evolution of academic community relationships in health research, and I'm going to pass it to Fern to discuss it.
So as you can imagine, when I started in the community ignored was the relationship of the community to research. Either we were being studied by someone or we were being completely ignored. That began to make progress in the 80s. And so in the 80s, we would see things like the community being acknowledged as being studied and what their role might be in a particular study. Again, not asking for community opinion, not asking for community input, but rather informing the community. By community informed, there was a little bit of dialogue, a little bit of what do you think, but it still never felt like the community was actually being heard. So, for example, a study was conducted by Columbia on the barriers to research within the Washington Heights and Inwood community regarding older adults. And the older adults and community-based organizations in the community thought, I don't think so. I think the barrier has something to do with the fact that you don't actually hear us or listen to us. And so the community partnered event came about when the community turned the tables, got an academic partner and studied the university and said, let's posit that the university is the barrier and see how that works. And so it really changed the dynamic between researchers and community when all of a sudden researchers understood that community could conduct the research as well.
Great.
So this is Kellogg definitions, Kellogg Foundation's definition of community-based participatory research, being that it's a collaborative approach and that it's an equitable approach that involves all partners in the research process. As a person who runs a nonprofit organization, I'm not interested in being patted on the head and sent to the edge of the room when research is being discussed. I'm interested in being in the middle of that conversation. I want to work to improve health outcomes. I want to work to eliminate health disparities. That's my priority. I don't know all of the researchers doing research, and I don't necessarily trust that they all have the same agenda that I do. And that reality gave me a big step forward into saying, I want to be engaged in CBPR. I want to have that conversation with researchers. I want to be equally listened to at the table. Could we go to the next? Thank you. Alejandra, this one's yours, babe.
Sure. And thanks, Fern. So CBPR isn't new. It is over 50 at this point, 70 years old. It has its roots in popular education coming out of Brazil. Also in community psychology out of Europe. But here in the United States, it really has gotten attention and it has come to be valued as it deserves for the power it holds in shifting power dynamics. and addressing injustices. It is an approach to research. It is not a research method like qualitative research or quantitative research. CBPR can be used with both or with mixed methods. It's about your relationships and the dynamics with your community partner and the community that you're engaging. So what is it? Like I said, it's an approach to research or to doing services, right? Service implementation. It recognizes the community as a unit of identity. It works with the community rather than in the community, as Fern described. There is a difference. If you are in the community, it doesn't mean that you are engaging the community in a meaningful way, in an equitable way. It integrates capacity building for all. And that can take many different forms, but it is action oriented just as much as it is capacity building opportunity for everyone involved. There needs to be an advancement that comes out of the CBPR work that we engage in. What it isn't is that it's fast. It is not fast. It takes a long time to establish these relationships because these relationships have to be based on trust and trustworthiness. And that's why I was very intentional to share with you that I've known Fern for, I want to say, at least 15 years. And we certainly did not start out as partners. If we go back to that table that I showed you about the community engagement continuum, I think certainly early we were in the outreach and consultation stage. As I started the position and I started to get to know the stakeholders in Washington Heights, Inwood, and I got to know Fern. And now we've done a couple of CBPR projects together. Fern also co-teaches our CBPR program, our class at Columbia. And that takes time. That takes a lot of time. And it's also, I always tell students, because I've taught the CBPR class before at Mailman, that this is a relationship. It is like a marriage. And so it is not for the relationship adverse. You have to approach these partnerships that this is a relationship that you want to be in for the long haul. And so now you really have to think about how your actions are going to affect your partner. And so the decisions you make have to consider how they might impact your partner, because now you're in it together. And so that's what's going to make you trustworthy and maintain that trust with your community partner, but also with community. Fern, anything you'd like to add?
Just that it requires you and your community partner to be honest. If you say to me as a community partner, honestly, one of the things I need at the end of this project is I need to publish because my career depends on it, I'm going to be okay with that as long as you make me a co-author. Mm-hmm. I don't want to be ignored of my contribution. I'm willing to help you write. I'm willing to help edit your submission, but I expect to get credit. I expect to help you think about what the results mean for me, for the population that I represent, and for the community in general, not just what it looks like it might mean based on a straight data analysis. Data analysis needs context in order to make it have value. And that context is what the community partner brings to the relationship in part.
Do you want to introduce the project?
So ARC 16 Fort Washington is in the 2/3 of the way through its second PCORI project. And we are the lead agency. Alejandra and many academics within the institution, as well as many other community-based organizations, are our partners in the research venture. And so prior to this project, we actually did a project on trying to engage the community in understanding and finding a CER question on metabolic syndrome. What we found out is we were biting off more than we could chew. Most seniors didn't really able to tease out what metabolic syndrome is. They understood diabetes, they understood hypertension, they even understood obesity and high cholesterol, but nobody had ever put it together as a thing that they should be aware could impact the rest of their health. And so we did a lot of work on that. We spent a year on it. And at the end of that project, we had an opportunity to look at, well, what about dissemination? Maybe engagement is not the end of the road for us. Maybe we want to engage to disseminate, build community capacity to disseminate research results. And when Alejandra and I suggested that to the group, and it was a sizable group of about 13 or 14 people, the seniors in the group said, you know, I don't really care about metabolic syndrome. You know what really impacts my life? When I fall. If I fall, it changes my life in a way that I couldn't have understood before the fall. And we need to have information that we can disseminate on preventing falls. And so the entire group, who had not even been thinking about falls prevention, pivoted and said, if the most important thing to the seniors in the room is falls prevention, then that's what we should really be looking at. And so what you see is a poster on our second project, which was building community capacity to disseminate research findings on falls prevention. And what we found out is that there are about 12 to 20 nationally accepted falls prevention evidence-based programs, and that those programs are not that readily available in New York City. Some of them are, some of them are not. They do tend to be available at least partly in senior centers, but it's a secret, nobody knows. So it's great that there are some resources in New York City, but how do we get from understanding that falls have a devastating impact to building an ability to disseminate that information throughout the older adult community, at least in Washington Heights and Inwood, which is our identified geographic area. So we're excited that the topic came from senior center clients. The steering committee, which included the seniors, have made all decisions from the beginning on governance practices, on methodological aspects. They have helped to design the project from the beginning. And so what we have done is we did a lot of research on falls prevention projects, on evidence-based programs. That's what EBP means, is evidence-based programs. The senior serving organizations assess their own outreach and how they outreach. What we found at the time when we first did that survey was that we were relying on handing out paper and phone calls and verbal discussion, that most of us were not particularly tech savvy. We were not, even if we were on the web, it was a non-interactive web experience for the client. So a few of us, 2 or 3, had Facebook pages. The majority didn't even have Facebook pages. And so we spent a lot of time thinking about what is our message. And then what is a message that will resonate with seniors, and how will that messaging best be disseminated? And we had a whole plan. We spent an entire year developing it, and then the pandemic hit. And all of a sudden, the senior centers are closed across the city. The senior service providers are all operating virtually, meaning mostly phone calls, not even very much Zoom. Only about 10% of Washington Heights and Inwood seniors are Zoom ready. Most of them aren't even internet ready, much less Zoom ready. A few of them have WhatsApp on the phone, so they're having conference calls through WhatsApp and through other conference calling means. And so we had to pivot again and say, there's a digital divide here. People aren't going to get the information they need to get. How do we do this differently? Alejandra, you want to pick up how we're doing it differently?
Yeah, so as Fern explained, we found ourselves in this situation, and it actually led to some creative thinking. It forced us, to think outside of the communication ways of communicating that we were accustomed to. And so we figured out that, well, everybody or almost everybody has television, and there are public access channels provided in Manhattan through the Manhattan Neighborhood Network, which we can utilize to disseminate health information that is specifically tailored and targeted to older adults. And right now we are applying for funding, and I just chuckle because I don't think we at the start of this never ever were we imagining that this was an option. And so now we're talking about basically becoming community producers, of a television series to disseminate health information to older adults. And it touches on capacity building, right? It's building on the foundational work done by the Fern's organization. It continues to collaborate and partner with the steering committee. In fact, another outcome of this project is that this steering committee is so supportive of this work and has bought in, because of the use of CBPR, has bought into this effort, that it has actually adopted its own identity. We are now going by the Lifespan Dissemination Alliance.
Wellness
Alliance, thank you.
They didn't want dissemination.
They didn't want dissemination, right?
Alliance.
So it's Lifespan Wellness Alliance. And they're in complete support of this project. Ends in May, and they're in complete support of continuing to meet and to figure out how we can actually produce these television shows, because one of, again, the other capacity building that came out of this was realizing that given the times, in thinking towards the future of what changes are going to stay, for example, the dependence on virtual communications like Zoom, we need to address the issue of disseminating and meet our community where they are. They are not on Zoom. They are not on social media. They are not coming out because the senior centers remain closed. And if, when they do reopen, it'll be at limited capacity. It is 3:23. I do want to be mindful of the time. So I'm just going to move on to our last slide. And, CBPR, this methodology is based on these 9 principles. And I wanted to go through all of them and then really focus on the ones that we had put into place. And as I began to bold the ones we had utilized, and I started with 1 and then went down, I realized, and I'm quite proud, that we've actually managed to implement all 9 principles in the year and a half, almost 2 years of this project. And I have to recognize that the fact that Fern had already these relationships with the other senior service providers, that it was through our partners that we were able to engage clients in the steering committee, that it expedited the CBPR process and enabled our ability to be able to put into practice these 9 principles. So, the first one is CBPR recognizes community as a unit of identity. And so we recognized the older adults that are members of our senior centers, as well as our senior service providers, as a community with a shared identity. As I mentioned, we built on the strengths and the resources of our partners. And all the work that they had been doing that led to this CBPR project. It facilitated collaborative, equitable partnerships. The way we even managed the meetings reinforced that we valued everyone's participation, and we were all equals, and we were bringing just different expertise to the table, but no expertise was valued more than others. It promoted co-learning and capacity building, and Fern went into the different types of co-learning and capacity building that we took on. And it integrates a balance between research and action for mutual benefit of all partners. And certainly we did undertake some research activities like the focus groups with clients. But we've also been able to use it for the benefit of everyone involved. We're all going to be able to use the deliverables and the tools that came out of the focus groups. Number 6, it emphasizes public health problems of local relevance. It was the clients themselves that said it's false, more than metabolic syndrome, that has an impact on our lives. But we're also looking at it from a much wider lens. We've also undertook this project using a cyclical and iterative process. We went back and forth, had multiple meetings with the clients until we arrived at an agreement, and everyone was satisfied with the dissemination products that had come out of those efforts. We're disseminating the findings and knowledge gained to all partners involved. We keep our steering committee and the clients informed. And also the Washington Heights Inwood Council on Aging selected falls prevention as the topic for their annual conference. So we'll be also presenting on this project and what we found at that annual event. And then lastly, it requires a long-term process and commitment to sustainability. And as we just described, we are committed to figuring out, with or without funding, how we will make use of television as a dissemination method. Fern, anything you'd like to add?
I'm going to say that I started out being one of those people that sits on an advisory board and is told to just sit there and listen and learn 22 years ago. And I didn't see myself as a researcher. I saw myself as an interested community member. And it's been a lot of process, a lot of different academics and clinicians saying to me to take it further to involve the organization in research, to enable seniors to participate in research in the way that I think they should be able to, that if I don't do it, who will? And I think that that's the message to nonprofits. I don't know how many of you on this are running nonprofits or working in nonprofits, but if we, the community, and we, those who run nonprofits, don't undertake research and holding researchers feet to the fire and saying it matters that you involve us, it's not going to come out of magic. It's not going to come out of the air. It's not going to come just because somebody thinks it's a good idea, because it's very, very hard for a researcher to get the reputation and the value to their research when they're doing something that is such a long-term commitment and in the beginning does not have a lot of return. So it's up to us, the community, to make sure that it happens. I'm
Great
open.
wisdom.
How about you, Alejandra?
I'm going to leave it there. That's the takeaway.
Thank you. Thank you. That was really great. I just want to say a couple comments that were said in the chat from Ms. Scanlon. She said, digital divide equals isolation. That was referring to the previous slide, and that every senior stands segment can be bicycled to public access stations in all 5 boroughs, integrating the outreach citywide.
I would like to be in touch with you, Francie. If you would put your contact info in the chat, I will.
Will do. Will do.
Because I want to know how to do it.
Okay, you got it.
Okay, I don't see any more questions or comments in the chat, but if anybody would like to say anything, Ms. Spencer has her hand raised. You can go ahead.
I just wanted to say thank you so much for this presentation. I enjoyed it very much, as well as the presentation on nutrition. I'm with the Bronx Community Health Network, and my core of my job is doing community engagement. And part of what I'm finding is that's also helpful is to actually hear the narratives of people who have participated in research from the community, where they're really speaking from the place of lived experience. And this way, you know, it sort of helps to tear down the barriers in terms of the sort of mystery of what research is like, or being part of research as a subject or a participant. Thank you.
Right, absolutely. And it's through community engagement that we can facilitate the voice of the participant. I mean, I also refuse to call participants human subjects. No, right? Do I need to explain further?
It's dehumanizing.
Exactly, it is dehumanizing.
Yeah.
And it's time to change that thinking and that disconnect between the researcher and the person that's actually providing that lived experience and that valuable data that allows us to learn and arrive at a solution. So hence why, you know, this is what I love to do, promote community engagement and the use of CVPR. Pleasure to meet you, by the way. I've heard a lot about you.
About
you, Paulette.
Really?
I used to work with your predecessor.
Okay, that's nice to know. Thank you. Wow.
Fern?
When I co-teach with another professor, CBPR, the first 2 classes are on power dynamics and inequity and how to partner, how to be listened to. It's the theme of the whole class, but the first 2 are power dynamics and what do we call the second one, Alejandra?
Race and privilege.
Thank you, race and privilege. I was thinking of the exercise we do, and I couldn't think of the name of the class. So that is from the beginning. From the beginning, we're saying there's an inequitable perception here, and I need to not think of myself as less because I don't work for a university, and you have to not think of me as less because I work for a private nonprofit. We are both aiming for the same thing. We are both trying to change the same inequities, and we have to first learn to deal equitably with each other.
Wow, I think, no, okay.
You can go ahead, Lula.
Oh, okay, no,
Yeah.
if there's more questions, I'm sorry, I didn't mean to cut in. So go ahead, Agnes, if there's questions, whatever.
No, I don't see any questions. I was just saying thank you.
Oh, okay. Well, I thank you. I thank you, Fern. I'm delighted to meet you. And when I ever get my computer straight, you'll see my face, but I'm delighted to meet you. Thank you so much for co-presenting with Alejandra today.
I have actually one comment, sorry, Lula,
No,
from
go
Jazzy.
ahead.
She said, how do you go about deciding what community you go into?
So I go into the community where I work. I work in Harlem, Washington Heights, and Inwood. I run services in all of Harlem, Washington Heights, and Inwood. So where would I rather do research than there?
That's the same for our program. Well, we our educators live in the community, so they know their communities best, and they give education in their communities.
Mm-hmm.
And I'll say that if you're, interested in working with the community that's outside of, where you work or where you live, it's, you have to start to get to know the organizations, who are the community leaders, and just, be open to the fact that it's going to take a while. If you think about when you move to a new neighborhood, how long it actually takes to get to know it, and that's where you live. And, so just keep that in perspective that it's going to take some time. And you have to learn about, the history of the neighborhood and in respect to how researchers have engaged that community. You should not neglect learning about the history, and be open to listening.
Okay, I think that is about it from the questions and in the chat. But if there's any further questions, please feel free to email me and I can reach out to the presenters here today.
Well, I'd like to thank everyone for attending these great sessions today. I am so delighted to meet Fern Hertzberg.
Likewise.
And your information is dynamic, and I just love the fact that you open up about what you don't know, what you need to know, and the power of politics, or the power of needing to know that you belong and letting everyone else know you belong. And it's going to take a little time, and you're ready, willing, and able to put in the time to make sure that your point comes across. Everybody understands you at the table to support community-based participatory research. I think that's dynamic. I think that's great. And I just love the collaboration that you and Alejandra have developed over time, long term. How many years was it again?
15. She knew me when I was single and child-free.
Oh, that is wonderful, wonderful. So you know something, she knew you then and she knows you now, and that is great because you really have a history, and that history supports the work, and it comes across in everything that you do. Dynamic, wonderful. I've enjoyed the presentation, beautiful. We had a great day today. Thank you all so very much. And looking forward to you guys coming back again. I gotta get that in.
Absolutely.
Absolutely. Yeah.
Okay, thank you so much. Everyone be blessed. Thank you.
You too.
Thank
Thank
you.
you. Bye-bye.
Bye-bye.
Thank you. Bye-bye.